Welcome everyone. This is the closing plenary for the ISCP 26 international meeting. And the title of this closing plenary is Decision Making. Does the Asian Paradox exist? We have four speakers today for this closing plenary. And our first speaker is Dr. Alan Fong from the Sarawak Heart Center. He is the head of the Clinical Research Center of the Sarawak Heart Center, Malaysia. And Dr. Fong is going to speak to us on ethnic differences in bleeding and ischemic risk in atrial fibrillation. Just a couple of housekeeping rules. Please remember to type in your questions into the chat, and we will try to answer them. We'll answer questions after the end of all four presentations. Ellen, over to you.
My name is Dr. Alan Fong. I'm a consultant cardiologist at Sarawak Heart Center, Malaysia. Today, my lecture will be on the effect of Dabigatran on clotting time in Asians. I have no conflict of interest to declare. Atrial fibrillation is the most common arrhythmia affecting the global population. The biggest difference in terms of atrial fibrillation in the East and Western population is actually in the sheer numbers. In this publication in 2014, you can see that the curves are much different in terms of patients expected to have atrial fibrillation in Asia in red compared to that in North America in blue. So for both male and female patients, the curves are exponentially much higher in Asia compared to North America as you get older, and more than 5 times the difference in terms of actual numbers. In Malaysia, which is a multi-ethnic population, we have some local data looking at patients with atrial fibrillation in our communities. On the left, a population study in the community showed that the prevalence of atrial fibrillation was approximately 0.5%. On the right-hand side of the graph of the slide is a study that we performed in patients with hypertension, and the prevalence of asymptomatic atrial fibrillation in this group of patients was thought to be 0.75%. Warfarin had been the mainstay for oral anticoagulation to prevent strokes and other systemic thromboembolism in patients with non-valvular AF. However, with the advent of new therapies, such as that of the novel oral anticoagulants, also known as direct oral anticoagulants, DOACs or NOACs, were produced and assessed at these different pivotal clinical trials, as you can see below for Dabigatran, Rivaroxaban, Apixaban, and Edoxaban. In these pivotal trials, it was shown that patients on NOACs had a lower risk for developing stroke or systemic embolism compared to warfarin. You can see the forest plot favoring NOACs moving to the left. On the right-hand curve, that you can see that for secondary efficacy and safety outcomes, the NOAC was favorable compared to warfarin, especially in the reduction in the risk for developing hemorrhagic stroke or intracranial hemorrhage. However, there are fundamental differences between all the NOACs. Dabigatran is a direct thrombin inhibitor compared to Apixaban, Edoxaban, and Rivaroxaban, which are factor Xa inhibitors. You can see that for Dabigatran, the bioavailability is much lower than that for the others. Dabigatran is a prodrug, not with the others, and predominantly Dabigatran is cleared by the kidneys compared to the others. So for Dabigatran, the other difference is that the plasma levels are also thought to be higher in patients who are of Asian ethnicity, and also associated with a lower GI tolerability with approximately 5 to 10% of these patients experiencing dyspepsia. So for Dabigatran, the plasma concentrations were assessed and published by the original investigators for RELY, showing that in the higher the trough concentration levels for Dabigatran associated with a higher risk for major bleeding, as you can see in the red curves. If the lower the Dabigatran trough concentration level, the higher the event risk for a ischemic stroke or systemic embolism in the blue curve. So if you had a Dabigatran trough concentration of approximately 90 nanograms per mil, you will pretty much be in the sweet spot that balances the risk of developing a stroke and against obtaining a major bleeding event. Another way of assessing drug performance is using the urine. So beyond taking a plasma concentration, there is now new technology, for example here the dipstick of the urine, to show the absence or the presence of taking a DOAC, and that could be used to assess complement. For our study, the plasma level concentration could also be directly associated with the clotting time, and the clotting time is what counts when patients are on anticoagulants. The clotting time can be assessed using a laboratory-based system such as the Stego assay on the left, or with a point-of-care system such as a Clot Pro, now acquired by Haemonetics, on the right. So I'd like to share a publication, piece of research that my team and I performed, entitled The Effect of Dabigatran on Clotting Time, and the Clot Pro Icarian Clotting Assay, published this year in the Clinical and Applied Thrombosis and Hemostasis. I'd like to acknowledge my colleagues and the research team and our patients for sharing our data. In this study of 126 patients with non-valvular AF, we enrolled 118 subjects into this study. The average age was nearly 70 years old, and 70% of these patients were male. They were from a multi-ethnic population, and most of them had some cardiovascular risk factor, especially predominantly hypertension. The mean CHEST-VAS score was 3.8, and the mean Hasbled score of 1.2. These are the primary results. On the x-axis, the clotting time in seconds against the y-axis for the plasma concentration of Dabigatran. The mean trough plasma concentration time was 59.8 nanograms per mil. This translated to a mean clotting time of approximately 361 seconds on the Clot Pro. The R was 0.80, and it was statistically significant. So pretty much a good relationship between the clotting time and the plasma concentration. As you know, most of the metabolism or the excretion of Dabigatran was through the kidneys, and therefore we assess the creatinine clearance as a variable to see how it would affect the trough Dabigatran concentration as well as the clotting time. In the graph above, you can see that a creatinine clearance of less than 50 mils per minute was associated with a higher trough plasma Dabigatran concentration as well as a higher clotting time. This was statistically significant. Therefore, in conclusion, the clotting time by the Clot Pro ECA POC assay reflected the plasma concentration of Dabigatran in patients with non-valvular AF. The current POC assay could also use to determine the impact of Dabigatran on coagulation status. So the implications are as follows. At the patient level, we are able now to balance the thromboembolic risk, especially for stroke and for bleeding. At institution level, a selection of specific patient groups who may benefit most from precision diagnostics, for example, those with renal impairment. And finally, at the national level, more scientific data is required at local populations, particularly here in Asia, especially when now most countries are available to access all 4 of the DOACs. So in summary, the key takeaways are as follows. First, DOAC use is likely to increase in Asia. Second, there is a balance required for thromboembolic diseases such as systemic embolism as well as the bleed risk. Third, the technology is now available to rapidly assess coagulation effect of DOAC at even patient level. And 4, more research is required in Asian populations to tailor therapeutic regimens for patients on DOACs. And I think with that, I thank you very much and happy to take any questions.
Thank you very much, Alan. Excellent summary of how we can use PK/PD evaluations to help us potentially guide therapy with DOACs. The next speaker is a good friend and colleague of mine. She's Associate Professor Doreen Tan from the National University of Singapore, Faculty of Pharmacy, Department of Pharmacy, Faculty of Science. And she will speak to us on the topic entitled The Riveting Truth About Rivaroxaban Serum Levels, the Caucasian Paradox. Over to you, Doreen.
Hello there, my name is Doreen, and I'm also the scientific chair of the ISCP annual scientific meeting this year. So welcome to our symposium on whether pharmacotherapy decisions need to be different in Asians. And welcome to sunny Singapore, albeit virtual. So where is Singapore? Singapore is this tiny dot of an island to the south of Malaysia. And this is a shot of Singapore at dusk, the beautiful island. Singapore comprises mainly of Chinese, of 60+%. Malays comprise about 20+%, and Indians comprise the last 10+%, with a few of the other ethnic groups. So today I'm going to be sharing with you about the riveting truth about rivaroxaban serum levels in our Asians. And I hope that by the end of this particular symposium, that you could be thinking about whether Asians could really be different than Caucasians with respect to pharmacotherapy. So I've got no conflicts of interest to report. And I would just like to set the stage with everyone thinking about how DOACs are being preferred over warfarin in stroke prevention in AF or SPEF. Now, this presents some problems if we do not know if we could routinely be using the same doses of DOACs in SPEF compared with warfarin. So what do we really know about rivaroxaban? Now, rivaroxaban comes in 3 different dosage forms, 10, 20, and 15 milligrams. Compared with Caucasians, we know that the higher the serum levels of exposure is greater in Japanese, even though the same dose can be taken in both groups. Now, what this means is that if you were Japanese, you will be receiving 15 milligrams every morning for SPEF. Whereas if you were an American, you'll be receiving 20 milligrams every morning of rivaroxaban. Now, this made us wonder, what about Singaporeans? Aren't we also Asians? So this set us on a journey to carry out a Singaporean study in collaboration with our folks over here. And one of them is speaking in the symposium, Dr. Alan Fong. Now, we compared the 2 groups, 15 milligrams and 20 milligrams maintenance dose patients, looking at both the Cmin, which is the trough levels, and the Cmax, which is the peak levels of rivaroxaban in both of those groups. You can see consistently over here that in the red bars that the Singaporean serum levels are consistently lower than the Caucasian levels on record. Now, this made us extremely curious, and that also set us on a journey to define the SingSat story, or the Singapore study of rivaroxaban and apixaban pharmacodynamics. We wanted to know whether this was going to end up in a sad or happy tale. Now, we set up to recruit 200 patients of AF. I'm very sad to announce that because of COVID, we had to slow our recruitment down, and therefore we had to close the study at 150 patients. So anyhow, we followed the patients through, and we took steady state peak and trough levels for these patients. We followed them up at week 2, month 1, month 3, month 6, month 12 to ask about their compliance, as well as whether they developed stroke and systemic embolic events, or SSEs, or bleeding events. Now, we came across some collaborators in the UK from the King's College of London, and we realized that they were also taking rivaroxaban levels for their clinical practice in patients. So we decided that we would compare steady-state trough levels between the Singaporean and the UK patients, assuming that ethnicity would be different, and it was panned out to be true because the large majority of the UK population comprised of Caucasians and Blacks, whereas for our population, as I mentioned earlier, was Chinese, Indians, and Malays. So our secondary objective was also to identify factors that could affect the trough levels or C-min-SS. And the subgroup analysis, which I will also present to you today, was on the systemic embolism rates as well as bleeding rates in the Singaporean cohort. Now, the main difference between the Singaporean cohort and the UK cohort was the Singaporean cohort was prospective. And Singaporean cohort had to be newly initiated of Rivaroxaban for over the last 3 months. So the patients were also instructed beforehand to take at a specific time Rivaroxaban before we took the peak and trough levels, so to ensure that the peak and trough levels were reliable at the time they came back for their appointments and blood draw in the clinic. The follow-up scheme was mentioned earlier. Now, there was a key difference between the assays used in the Singaporean cohort and the UK cohort. But because the correlation was close to 95%, we don't think that this is going to be clinically relevant or significant. What were we actually trying to measure? Now, the Cmax-SS, as known to everyone in clinical practice, would actually be the peak levels. So we're talking about a patient population who are on regular dosing of Rivaroxaban, and the peak levels were measured in our study. However, that was not measured in the UK study, and therefore I will not be talking about the peak levels in this particular analysis. What we're interested in comparing between the Singaporean and the UK population was basically the the trough levels, and we used a published reference range of 12 to 137 nanograms per milliliter. We were interested in the key differences between Singaporean or UK populations, if there were any to start with. The baseline demographics, as you can see over here, the UK population were significantly older and heavier. And the time from the last Rivaroxaban dose seemed to be shorter with the UK population, but I think this is not clinically relevant given the half-life of Rivaroxaban. Comparing the two dose groups, the 50 milligrams dose group was actually close to statistical significance. And potentially, if we had expanded this subgroup, there could be actually statistical difference between the two. However, there was no difference in the 20 milligram dose groups. If you look at the two charts visually, you can actually see that the serum levels for the Singaporean group tended to be lower and tighter as opposed to the UK subgroup. Now, we put the whole group together with a 252 subject population. And what we were interested in looking at was predictors that were higher than range or lower than range. Now, because lower than range were hard to pick up with respect to the assay that we used, which was the Biofan as well as Stago, we ended up running predictors only for higher than range because we felt that that was more reliable. So we are looking at the risk factors that could drive people that were above the range that's indicated by the red arrows over on the left-hand side. So we saw that the UK cohort was fourfold more likely to be above the trough range, meaning that they're probably safer in the therapeutic range, somewhere lying in the window over there. Now, where the therapeutic range actually lies with respect to benefits for stroke risk and bleeding risk, that is not been well defined in clinical practice. We also saw that creatinine clearance or renal function was still a predictor in spite of the fact that the cohorts, geographical regions, and of course a surrogate for ethnic groups was an independent predictor. And also the 50 milligram dose group was close to significance in this particular model. And I suspect that if the population was larger, that the 50 milligram dose group could also become a significant predictor of people having higher than range at the trough levels. So what does this mean with the Singaporean cohort? And the clinical outcome rates are presented in the green box on the left-hand side. So in general, the median CHEST score in the Singapore population was 2, and they ranged between 0 to 7. Now, if we were expecting a CHEST score of 2, it would mean that the annual stroke risk for any patient would probably be about 2+% up to 3%. Now, proper anticoagulation will reduce that stroke risk probably by 2/3, and therefore you would expect the annual stroke risk to be less than 1% or about 0.8%. Now, what we observed was that our local population stroke rates were as high as 3%, and this actually translates to almost not being anticoagulated at all. Now, this was extremely alarming. And so we compared with the rates in the Xanthus study, which was also a real-world study using prospective patients observationally on Rivaroxaban. Now, the TEE rates was twice as high as was the bleeding rates compared to the Xanthus study. And this was something that we found to be extremely alarming, knowing that the Singapore cohort, which was predominantly Asians, could be at risk of strokes even though we were being anticoagulated, and also at risk of bleeding even though we were using the labeled dose of Rivaroxaban. So I called to mind a 1,700 patient population retrospective database study, which was a collaborative between 6 centers in Singapore, done all the way back in 2018. Now you can see numerically that the apixaban patients were higher risk of SSEs, and clinically relevant non-major bleeding was higher with warfarin as well as apixaban. If you apply inverse probability of treatment weighting, which is something like matching the cohorts, you can see that the effect with apixaban compared to warfarin at risk of SSEs was almost fourfold as high. Now, this is actually a bit troubling where we are concerned, because if we cannot measure the impact of DOAC levels in our locals, do we then wait for them to develop a stroke before we react? So what we saw was also that CHEST score was higher with warfarin and apixaban subgroups, and apixaban median risk score was at 3. That could potentially explain why, but still the higher CHEST score with warfarin does not explain why apixaban patients tended to be on higher risk of SSEs. Now, HASBET was higher with the warfarin subgroup, and that could explain why there was more bleeding seen with the warfarin subgroup. We also noticed that the apixaban patients tended to be dosed too low, but that was probably not enough to explain the impact of the fourfold risk of SSEs compared with warfarin. More patients were dosed too high with the Rivaroxaban subgroup. Now, this actually shows us that in the Asian population, there's lots more that we need to be doing with respect to dosing and the impact of DOAC dosing on the clinical endpoints of strokes and bleeding. So in summary, ladies and gentlemen, I put to you, Singaporean Asians are not Japanese Asians, and they're unlikely to require a lower dose like Japanese. In fact, there may be suggestions that we might require maybe even a higher dose, but I think more needs to be done in order to define this more clearly. The renal function, regardless of ethnicity or geographical regions, it still stays important. And it seems to suggest that poorer renal function tended to suggest that levels of DOACs will accumulate. Now, this has got important implications if we've got patients who've got drug interactions that become more important when patients are renally impaired. And so a lot more work needs to be done about this. What about geographical and ethnic differences? There seems to be suggestion that our locals tend to have a lower level than that in the UK population in our study. So clearly, more needs to be done in this aspect in matching out so-called therapeutic ranges with clinical outcomes. So why are there more TEEs and more bleeding in our locals? Ladies and gentlemen, all those of you who are Asians out there, I reach out to you with my wholehearted plea. I think we need a lot more work done in this area in Asians. So with that, I hope that with our sharing that you have developed also the same curiosity as I, that perhaps in Asians, the decisions about pharmacotherapy doses and choices could be different. So with that, ladies and gentlemen, we will open the time for the Q&A. Thank you very much.
Thank you very much, Doreen. The next speaker is Professor Yong Hoon Jeong, and he's from the Gyeongsang National University Hospital in Korea. Young Hoon and I have known each other for quite a few years now, and he's an accomplished clinical trialist and an expert in the field of thrombocardiology. He'll be speaking on the topic genotype-phenotype guided strategy. Are there interracial differences in clinical benefit with antiplatelet treatment? So now over to you, Young Hoon.
Thank you, Chairman. Recent update consensus recommended to use a play function test genotyping guide depth FTPCI in specific clinical situations. In high bleeding risk, we can use that de-escalation based on play function test and genotyping. For complex PCI, we can use that escalation based on the play function test and genotyping. However, this kind of strategy, clinical benefit would be different between the races, especially East Asian have a unique clinical features. These features was indicated by East Asian paradox. This concept firstly was introduced by Dr. Yong Jung in 2012. In this concept, Dr. Jung points 3 unique profiles in East Asian. Compared with Western population, East Asians show the high bleeding risk and low ischemic risk, and the different response to p12 inhibitor and the NOAC. Maybe East Asian need different optimal potential duration of that compared to Western population. Following the experts could publish the consensus document in 2014, 2018, 2021. There are numerous evidence to support the concept of East Asian paradox. Today, I'm just suggest a representative result. This meta-analysis involved 7 RCTs to compare clinical efficacy and safety of short-term and long-term depth after PCI. 9,000 East Asian patients and 8,000 Western patients. Irrespective of antiplatelet regimen, single or dual antiplatelet therapy, Western population have shown the increased risk of ischemic event almost twice. These races show the low risk of ischemic event, low risk of bleeding event compared with the East Asian population. Today, I would like to criticize the universal application of a play function test and genotyping guided antiplatelet treatment in PCI patients based on the below clinical observation. First, compared with Caucasians, East Asians have different therapeutic window, different cutoff of high platelet reactivity, HPL, and low platelet reactivity. Because we need to use the cutoff of HPL, LPL to adapt to play function test. I already mentioned the East Asian have a low thrombotic event and high bleeding risk. If we apply this concept, East Asian patients may have different therapeutic window compared with Caucasians. Fortunately, now we have multiple clinical evidence to show the different cutoff of HPL in East Asian. Almost 12,000 patients data show the PLU 250 to 270 would be the cutoff of HPL for East Asian. It's so different with the Western cutoff of HPL 208. Recent PTRDTS registry enrolled the Korean PCI patient treated with clopidogrel with the play function test of genotyping. In this registry, almost 12,000 patients had peripheral test. Based on the time-dependent Atherosclerosis analysis, the cutoff of HPL was 250, is higher than Western cutoff. AMH trial performed by our group tested the clinical safety of reduced prasugrel versus play function test guided strategy and guideline recommended regimens. This study suggests the different cutoff of LPR for bleeding in East Asia. The cutoff of PRU is higher than Western cutoff of PRU 85. The cutoff of HPR and the LPR in East Asian were higher than Western cutoff. Second, compared with Caucasians, East Asians have a different response to P2Y12 inhibitors. After pre-function test and genotyping test, we need to adapt the alternative P2Y12 inhibitors. However, East Asian shows a different response to P2Y12 inhibitors. Now we have three options: clopidogrel, Rivaroxaban, and ticagrelor. For clopidogrel responsiveness, CYP2C19 loss function is most important. For Caucasians, intermediate metabolizer and poor metabolizer, the prevalence is almost 30%. For East Asian, this prevalence is almost 60%, almost twice. Especially prevalence of a poor metabolizer with 2 loss function allele is almost 5 times higher in East Asia. These observations indicated low response to clopidogrel in East Asia. Contrary to clopidogrel, response to rivaroxaban or ticagrelor in East Asians were markedly increased in East Asians. Blood level is almost 40 to 50% higher in East Asia. For standard dose of clopidogrel, the matching partial dose is different across the races. For East Asians, rivaroxaban 205 mg is equal to clopidogrel 75 mg. For clopidogrel, rivaroxaban 5 mg is equal to clopidogrel 75 mg. Therefore, East Asian patients must have different optimal antiplatelet regimens. Recent evidence from RCTs, including ACS, showed interest finding compared with the standard dose clopidogrel, doubling clopidogrel, adjunctive 실로사조, low dose rivaroxaban could reduce ischemic event. However, standard dose of rivaroxaban ticagrelor did not reduce ischemic event compared with the standard dose of clopidogrel. Third, compared with the Caucasians, East Asians have different influence of CYP2C19 genotyping on clinical event. In PTLDS registry, we could enroll about 8,000 patients with the genotyping. Almost 60% patients were intermediate or poor metabolizers. Across extensive intermediate and poor metabolizers, the level of predictivity was increased. However, there was no difference of incidence of 5-year death, MI, stroke, stent thrombosis across EM, IM, and PM in East Asia. PLFCI compared the clinical benefit of genotyping guide treatment versus conventional clopidogrel treatment in loss functional RLS in each 1,000 patients. In this trial, East Asians was enrolled about 45%. For conventional therapy, clopidogrel was mostly used, whereas genotyping guided for this therapy, ticagrelor was mostly used. Compared with conventional therapy, genotype therapy could reduce the ischemic event, but this benefit was mostly observed during 3 months. If we compare with this benefit between East Asian and Caucasian, for Caucasians, genotyped strategy could reduce ischemic event 2 or 6 with mild increase of bleeding. However, for EST agents, the benefit by genotyping 1.4% with marked increased risk of bleeding. No benefit in this agent. Preserve the benefit in Caucasians by genotype guides strategy. Finally, we need to think about dynamic change in influence of platelet deactivity on clinical event. Even though patients were treated the same regimen or antiplatelet treatment, platelet inhibition influence was changed over time. During active phase, platelet inhibition is more related with destruction of ischemic event. However, after active phase, influence of platelet inhibition is more importantly related with the bleeding risk. Gyeongsang National University registry, we could note serial PRU measurement in PCI treatment. About 3,000 patients during hospitalization, and after 1 month, we checked verify now, and we try to evaluate the relationship between platelet deactivity and the ischemic event. According to the Cauc proportional analysis, the relation is the most important just after PCI, and over time is a decrease. After 3 months, there is no significant relationship between platelet deactivity and ischemic event. But if you just select the MI patient, the relationship is more increased and maintains over time. However, after 6 months, there was no significant relationship between PRU and the ischemic event. Now we have multiple evidence to use de-escalation strategies of that in the EST agent patients. For example, short depth aspirin discontinuation, uniform disease dose Pharmacotherapy and Tachycardia, switching strategy with Clotting. However, unfortunately, we don't have any clinical evidence to offset phenotype or genotype guide strategies for EST agents because the Taylor PCI was failed to support the clinical benefit of genotype guide strategies in EST agents. Precision medicine, such as play function test genotyping guide antiplatelet therapy, is kind of dreams come true in someday. However, there must be a long, long way to go because these laces have so different clinical efficacy and safety during blood thinner and the different response to blood thinner and the different thrombocyst, etc. There must be a long, long way to go. Thank you for your attention.
Thank you very much, Yang Hun. Now we go on to the final lecture in this session, and this lecture will be given by Professor Heinz Drexel from the Vorarlberg Institute for Vascular Investigation and Treatment in Austria, and Professor Drexel will speak to us about LDLC target, the lower the better in all coronary artery disease patients. Over to you, Professor Drexel.
Welcome, ladies and gentlemen, dear colleagues, to a talk about LDL cholesterol target. The lower the better in all coronary artery disease patients is the question we are asked. Here you see my curriculum and here my disclosures. Now we have the outline to explain LDL cholesterol and the way to atherosclerosis, and then to focus on interventions. Let us start with the connection between LDL cholesterol and atherosclerosis. Here you see the blood lipid transporters. We have in blood different types and sizes of lipoproteins. The important one for us today is the LDL. This particle is the main cholesterol carrier, and whenever we say LDL, we mean the total particle. When we say LDL-C or LDL cholesterol, we focus on the cholesterol in these particles. Now, this LDL, if you look at the arterial wall, has long been postulated that it is causal for atherosclerosis because it travels in the blood and arrives in the plaque or in the intima. And now we know for sure that this is true, that LDL is causal for atherosclerosis. And you see here that the LDL travels to the intima, but not to the muscular layer of the arterial wall. So it is clear it comes from the blood and is not all over in the arterial wall layers. Now, we can now conclude that LDL cholesterol is causal and cumulative for atherosclerosis. What is the evidence for that? We know from epidemiology, from pathophysiology and histology that this all fits into the causal role in LDL-C, as we have just seen. This is also true for animal studies. It is now true for Mendelian randomization studies, a very modern type of looking at the natural randomization in our genes. And of course, we want to know whether this causal role of LDL cholesterol is also supported that it is reversible by therapy, so that lowering of LDL cholesterol is good against atherosclerosis. Now, this is a paper we just published from our working group, and we looked here on the total cholesterol readings, which is a reflection of LDL cholesterol, also not precisely the same. And here we could show that earlier in life, the cholesterol is more powerful than later in life as a predictor of cardiovascular disease. And you see, we had here data about 15 years plus 19 years when we made first a study in the healthy individuals and then looked at those patients that later on had coronary angiography, and we followed them up then for 19 years. So the conclusion is very clear. The longer the cholesterol is high, the worse for our arterial wall. So we can have the conclusion. Early measurement not only enables early intervention in keeping with the concept of lifelong exposure to atherogenic lipoproteins. These data also suggest that cardiovascular risk prediction is more accurate if using earlier in life total cholesterol readings. And of course, this would also be true for LDL cholesterol, but we had no such data 30 years ago. So this proves the concept that LDL-C is not only causal, but also cumulative for atherosclerotic cardiovascular disease. Now let's move on. If that is true, we must say that when we detect coronary artery disease in a patient, we are always late because we have missed the preclinical phase, the period when atherosclerosis developed but did not end up with an endpoint like myocardial infarction. Now, from this, we can go on to interventions. As we have seen before, we want to know whether interventions also prove the concept of causal role of LDL cholesterol. Now, here we can allude to the very nice data collected in Oxford by the cholesterol treatment trialist collaborators. And I just show you here some crucial data. If we look at a risk reduction in the LDL cholesterol level by 1 millimolar, which is 38.7 milligrams per deciliter, if you are more used to that measure, then we see 1 millimolar lower, it produces 24% less cardiovascular events. It goes along with a 24% lower revascularization rate. And also, most importantly, I could say 15% less stroke incidence. And altogether, the vascular events, so a summary of all the events we can observe, it is minus 21%. So an easy calculation to remember is 1 millimolar reduces about 20% of all events. So the lower the better in all coronary artery disease patients was the question addressed to me. And there we have exceptions from the rule. We have limited life expectancy. We must admit that if life is expectancy is lower than 2 years, then probably lipid lowering has no measurable effect. And there is drug intolerance when people do not take the lipid lowering drug. Altogether, this is quite few. We could now go into more details, but I think you in Singapore are more interested if there is an Asian paradox, which is also the title of this session. So let us first look at subgroup analysis, because we must look at subgroup analysis to answer the question if there is an Asian paradox. And we have just published this paper on the value and the limitation of subgroup analysis. And to make this long paper short, we can say that treatment benefit may vary according to patient characteristics. Most phase 3 randomized clinical trials recruited very heterogeneous populations, coming from different countries and regions or even continents. That's the topic now, with major differences in race, also comorbidities, and other points you see here. Next point is geographic differences in multinational trials may affect trial outcome. This now increases our interest on the question whether there are exceptions from the rule. And please remember for a minute that the comparator in modern randomized clinical trials is not always placebo. If I may just introduce you to the next slides, we know first we had statins versus placebo in our trials, and then we added further statins with higher efficacy and compared them with lower efficacy statins in terms of LDL cholesterol. Later on, we had other drugs to reduce LDL cholesterol, for example, ezetimibe. And very recently, we have, of course, the PCSK9 inhibitors, which we will focus on in a second. Namely, we had the first one, the very famous Fourier Trial, and now let us investigate this trial, whether we have subgroups. First, it is very important what was the recruitment rate from different regions. And here, for Fourier, we have seen in the original publication that Asia Pacific and South Africa were taken together, and they were around 14% of all participants. You see here the majority was from Europe. Now, Sabatin and co-workers did not show in that paper any results on geographical distribution, so we can go on to the next trial that answers also this question, Odyssey Outcomes, published a bit later with the other PCSK9 antibody. And here now we see that again about 13% Asian people, and also the region of enrollment, which is not necessarily the same as the race, is about 12%. So it is always, you could say, 1 out of 8 is from Asia in these trials. Now, Schwartz et al. In the supplement of their study showed us some very interesting data. Now, here we see the primary endpoints in pre-specified subgroups. First, the Asian population, the race here, you see, this is interesting. The Asians are different from, for example, Black Americans. But what we also want to look at is that the range of the distribution overlaps if you look at these two distribution bars, although the point estimate is quite different. And because of that, the p-value of an interaction term, which was made correctly in this study, this does not differ. This means, of course, that the result of the study is valuable for the total population, and we should not exclude Asian patients from our conclusion. And you see here, if you look at the region, it is quite similar. But now it is very interesting to look at these numbers in detail, and you see the point is that the placebo, which is not just a placebo, but it's a high-dose statin therapy, that this placebo group has a very good result, much better than in the other regions. So this is probably different from just the intervention. If we now look at the result, we could say that the surprise here is in the placebo group. So next, we are now interested in racial differences in the statin effects, because statins were the comparator in this last mentioned trial. And here we have learned from Naito et al. That racial differences exist in the response to statins between Asians and Westerners through different pharmacokinetics, which is partially explained by genetic factors, and that future research is required to elucidate to some extent the gene factors that are associated with racial differences in statin response. Very interesting work for researchers in the future. Next is the question, is lipid goal one size fits all? In this nice review by Wang et al., there was a clear conclusion that owing to the geographical, ethnic, and genetic and cultural diversity in Asia, the one size fits all lipid recommendations seem less practical. The challenge remains for individual countries to implement clinical trials in local population to validate international guidelines. So again, for us as researchers, interesting topics. And this research then may emphasize the development of local scenarios incorporating the local evidence and availability of new lipid treatments. So the lower the better also in stroke patients may be the last interest we have, and we have published that from Odyssey Outcomes. And just to make a long story short, if you look at the green lines, any stroke, this is much better with the lower alirocumab group. And what this also showed us that the alirocumab has not more hemorrhagic strokes, a myth that we had in earlier years. So we can conclude, and this may be quite interesting for you to differentiate it from antiplatelet drugs. We have no increase in bleeding, and Odyssey outcome stroke trial is the proof for that. So to take home, I think we have 4 messages. LDL is causal and cumulative. The lower the better is true for all CAD patients. The earlier the better is true, and few exceptions from the rule, mainly limited life expectancy. And I must leave you with the question, is there an Asian paradox? Yes or no? Thank you very much for your attention.
Okay, thank you very much for 4 excellent speakers. First two speakers described about NOAC and atrial fibrillation prevention of stroke, difference between agents and Caucasians, and Professor Jeong made a wide review of the antiplatelet therapy after PCI. And lastly, Professor Heinz Drexler made, of course, the lower the better is established theory, but in Asian, it's a special population. At present, there's no clear evidence that the lower the better is applied to Asians. That's very interesting. All of the lectures are very interesting. Now, there is several questions. Okay, maybe just take one question. Rivaroxaban was used in COVID-19 patients as well. What has been your experience there? And I think there was a discussion about the COVID-19. Could you make a comment from Professor George Dan?
Thank you, Koji, for this question. I have no experience with Rivaroxaban treatment in Asian patients with COVID. What I can tell you that probably Rivaroxaban is among the drugs most used in for the among the NOAC for the COVID patients, but we don't have at this moment any solid evidence that this drug should be used in patients with Rivaroxaban, besides other indication for using the drug, for example, patients with atrial fibrillation. So if you are asking my personal view, I would not recommend Rivaroxaban in patients with COVID-19 if they have no other indication for NOAC. I remain close to the indication of prophylaxis with low molecular weight heparin. And you, Koji, also presented yesterday that even this is not suitable for many of the Asian patients. But if you allow me, I will want to make a general comment. The term Asian paradox is for me unsuitable, because the paradox after the Oxford definition means something contradictory or absurd. So I wonder if it's the European paradox or the Asian paradox. It depends how is the view of the person. The only meaning for me is that we are going rapidly from the global evidence-based medicine to the personalized medicine, and we need to have guidelines and views for each region and different populations, including racial differences, geographic differences, and even more economic differences.
Thank you very much for your excellent comment. I think that Asian breeding are more and thrombosis is less. This is the general conception, but I think we need more research for individually and each country, and even within one country. Singapore consists of many populations, and not only Asians, Indians, Malaysians. So let's go back to the discussion about the antiplatelet therapy and anticoagulation therapy between the Asians and the Caucasians. I think that Doreen showed that the lower concentration of Rivaroxaban in Asian compared with Caucasian, but actually that when we look at the clinical data, even though the low dose of Rivaroxaban, clinical data show that the same level of efficacy between Caucasian and Asian, but the bleeding is much less in Rivaroxaban compared to warfarin. So I think, well, even though the blood level is low, it's enough to prevent the thrombotic event in Asian, and sufficient to reduce the bleeding event in Asian. How do you think about it?
I
I
suppose
guess
I'm
this will be
supposed
a
to
good
answer.
question for all our lecturers, presenters for this symposium. Doreen,
Yes,
Alan, and Yonghun.
all the lecturers.
Maybe I'll start because I was the one who created the controversy. I think the key thing about serum levels for the DOACs, unfortunately, is it's not being matched with clinical outcomes. And so, Prof. Koji, you're absolutely right. There is very little information that we have of what is a therapeutic range for both Asians as well as even the Caucasians. It's unlike the INR where we know somewhat clearly that the target range is 2 to 3. There have been associations with edoxaban as well as rivaroxaban that high trough levels could be associated with bleeding, but with apixaban, that data doesn't seem to be as clear. One thing remains to be true. On the contrary, compared to, say, stent thrombosis or MACE, it seems to be lower in Asians, whereas for strokes, that's the other way around. We have very high rates of strokes compared to Caucasians. I'm unfortunately unable to tell what really is causing this problem. It's unlikely just due to the DOAC levels alone. I think that is probably a coincidence that we found that the lower levels are seen in Asians. But it also begs the question whether we should be looking at this in a total question, total picture per se. Could it be that there are other risk factors beyond just the anticoagulation with DOACs? It's just very tempting to try and look further with the DOACs because there is some way of measuring it now. But I do think that blood pressure, as well as maybe even lipids and diabetes, needs to be looked into as predictors for stroke rates in Asians. Thank you.
Dr. Alan, is there any additional comment? Even though the bleeding is high in Asian and the thrombotic event is low, but how do we convert into the clinical setting?
I think, thank you, Prof. Koji and Mark. Yes, this is an area of great debate. And as we move from warfarin to NOAC, we are less likely to be interested at the pharmacodynamic situation at a per patient level. Otherwise, we will go back to measuring INR equivalent type levels. Therefore, looking at the EHRA document published this year on NOACs and non-valvular AF, plasma levels have been quite well documented in terms as for trough and peak levels. But there are still debate on whether we use that alone or looking at the pharmacodynamic property or variables. So we have just shared some data on Dabigatran, but I look forward to seeing others, particularly here in Asia, to provide data also on the factor 10A inhibitors. Ultimately, if you look at the plasma levels, we are more worried actually more of the bleeding situation rather than for stroke. So I think plasma levels of perhaps over 120, 130 for Rivaroxaban would be more of a concern. Similarly, for levels of over 280, 300 for Dabigatran. So I think a lot more work needs to be done, I agree. And hopefully this conference will add to that interest. Thank you.
Yes, thank you very much. Rangroj is a specialist of atrial fibrillation and anticoagulation. Do you have any additional comment on the anticoagulation, and specifically in Asia?
Yes, yes, I'm interested in the data of Singapore cohort presented by Doreen. Because I think that it's interesting that at the same dose of Rivaroxaban, the serum level of Asian population seem to be lower than Westerner, and the event rate is higher, both bleeding and thrombotic risk. The data, I try to look at the data from other study. We know that bleeding risk, as Professor Koji mentioned, that Asian population have high bleeding risk, but I do not notice that the serum level is lower than Westerner. I think that is maybe different pharmacokinetic, pharmacodynamic, or it also may involve genetic or racial difference that I think that more study need to be done in Asian population and the relation between serum level of different anticoagulants. I also interested in the data of Japanese people in elder care that they use very low dose of edoxaban, and they show that the event rate is okay and no complication. This is in very elderly population that they think that the very low dose may be an alternative treatment. But the data presented by Doreen, even at the same dose, the serum levels seem to be lower in Asian, which is the data seem to be contradict. And I don't know what is the good explanation for this. I think that many more studies need to be done, both for the cohort looking at event rate and also pharmacokinetic, pharmacodynamic serum level. I think that more study is needed.
Okay, thank you very much. Okay, let's go to the antiplatelet therapy after PCR. This is very complex. That again, the bleeding is more in Asian. The thrombotic rate is low in Asian, but in case of after PCI, there are a number of factors affecting the thrombotic event. How do you think about? For example, the type of stenting is different, and in IVAS is frequently used in case of Japan. So is there any comment about the difference between Asians and Caucasians about the antiplatelet? And Professor Jeong, please.
Actually, now we mostly use a similar updated clinical practice across the Asians and the European countries. I think the most interventions they can do their best, and the result looks so excellent. At this point, I would like to mention the role of thrombogenicity. Actually, thrombogenicity is so complex, I know, but the inflammation and the coagulation activity. I mentioned the thromboinflammation cascade. The activity is so different across the Asians and the Caucasians and the African Americans. Recently, our group collected some thrombogenicity profile from the COVID-19 patients, and we can collaborate with American patients, including African American and Caucasian and Hispanic. Even though they had similar WHO COVID-19 grade, the thrombogenicity level is so different. East Asian showed the low risk. Next is the Caucasian, the Hispanic, and the African American showed the highest level of thromboinflammation cascade. Likewise, I think that the PCI patients, their outcome is so related to be the thrombogenicity. This trial group hosted many interesting data in terms of this issue. You can find some interesting findings. I believe the blood thrombogenicity is one of the main reasons to explain to support the racial difference in clinical outcome.
Thank you very much for your comment. And is there any additional comment from George about both anticoagulation and antiplatelet difference between Caucasians and Asians, or ethnic difference? And you can also describe about the difference, ethnic difference on LDL cholesterol. Professor George Dan, please.
Thank you. I think all the speakers presented the personal experience and presented excellent material emphasizing differences which could exist between different regions on the world. And also Heinz presented his conclusion about the LDL cholesterol, which also emphasized the differences. Two things seems to me very important. First, there are no extreme of the spectrum. In my opinion, there is a continuum between different populations. So in between the Asian population known with higher risk of bleeding compared to the European, and the lower risk of thrombosis, and the reverse in the African population in the United States with a lower risk of bleeding but higher risk of thrombosis. There are a lot of intermediate degree of the spectrum. So what is very clear for me, and what I have learned for this excellent presentation made by Doreen, by Professor Jong, by Professor Fong, by Professor Rungroj, and other colleagues and Heinz Rexer, is that we need rapidly go from the global guidelines indication to the very specific indications in the local guidelines, and we should harmonize the general concepts with local experience. It is clear that atherosclerosis is inflammatory and a lipid disease, but the reactivity to the armamentarium we have at this moment for this disease is different in different populations. It is very clear that atrial fibrillation is a result of the atrial cardiomyopathy disease with increased risk for thrombosis, but the degree in which the anticoagulant therapy and antiplatelet therapy for the patients with coronary artery disease should be modulated in a personal view after the regions and the population we have to care on.
Okay, thank you very much for excellent lectures and excellent discussion. Thank you very much for joining this session. And I'd like to close this session, but I'd like to sincerely congratulate President Jack Tan and Doreen Tan as scientific chair, and Dr. Mark Chan and all of the Singapore team. A great success. And thank you very much for everyone. And I'd like to close this session.
Thank you.
Okay, thank you.
Have a nice day.
Hello there. Thank you for staying online with us. Now is the time to announce our winners of the presentations and the abstracts. We have received excellent work. So I'd like to announce the winner of the Young Investigation Award. And the winner is Mr. Yuto Kawase, University of Shizuoka, Japan. And his abstract is on compound A, a ginger extract, which significantly reduces pressure overload-induced systolic heart failure in mice. Congratulations, Mr. Kawase. And next, we will announce the 3 winners of our oral presentation. And the third place goes to Professor Shinzo Sonoda. And he's Professor, Faculty of Medicine from Saga University Medical Center in Japan. His abstract was on clinical efficacy of intracoronary papaverine after neocorrendal administration for safe and optimal fractional flow reserve measurement. Congratulations, Prof. Sonoda.
Thank you.
And the second prize goes to Ms. Ileana Susilawati, and she's a medical doctor and research assistant at the Biomedical Department, Medical Faculty, Brawijaya University, Malang, Indonesia. And her abstract was on polysaccharide peptide of Ganoderma, lucidum reducing endothelial injury in stable angina and high-risk patients. Congratulations, Ms. Susilawati. And the first prize goes to Dr. Shu Nakao. And he's a veterinary cardiologist from Ritsumeikan University, Kyoto Medical Center, Japan. His abstract is on beta-3 adrenergic receptors in the sinoatrial node for heart rate regulation. Congratulations, all winners. Thank you very much for your participation. So we will now take a nice picture with whoever is still around. Congratulations. Bye.
Thank you very much. Well done.
All right, so now it leaves me to close the session, and we will now have our president of the ISCP and also the chairperson of the meeting, Dr. Jack Tan, to address us with his closing speech.
Thanks, Doreen, for giving out the prizes, and congratulations to all the winners today. Well done. My name is Jack, the president of the ISCP, and I would like to give a few words of thanks in the closing ceremony for this 2 days proceedings. I would first like to thank Team Singapore, and this team did very well putting together the program as well as moderating the sessions for these 2 days. Well done, Team Singapore. I also like to give a warm welcome and thanks to the faculty members, truly a very international faculty for this 2 days events, and they contributed to a very nuanced and international program for ISCP this year. Special thanks to Professor Barbara Cassidy, the Henry N. Newfield Memorial Lecturer of 2021. And we had lots of riveting, insightful, and impactful sessions, starting with cardiovascular implication of COVID-19 as our opening plenary lectures, followed by interventional pharmacology, balancing ischemia versus bleeding. We had a great debate sessions on DM management, the role for sulfonylureas. We had a very good basic science session on inflammation, atherosclerosis, the missing therapeutic link. We had the role of team-based contemporary roles of pharmacists as CV team members. And we also had a great opening session on heart failure management. We have follow-up sessions by the board members when your atrial persists in fibrillation, and clinical pharmacotherapy in hypercholesterolemia, targeting the bad, not forgetting the ugly. So truly, we are focused on the run of cardiovascular pharmacotherapy from hypertension, atrial fibrillation arrhythmias, heart failure, basic science, and presentations of oral abstracts. So it was truly a very full 2 days. I'd like to acknowledge our sponsors and partners, as well as our media partner MIMS, for which this event would not have been possible. I also like to give a strong word of thanks to the Asian Pacific Society of Cardiology's support, and also the Singapore Cardiac Society for hosting and supporting financially this event. Special thanks to the ICP Board of Directors, who has contributed to the run of events and the programming scientifically of this Congress, as well as to the advisors to the board. Also, special thanks to the ICP Council Governors, a truly transcontinental group of advisors to the ICP as well. And last but not least, the most important folks on this call are the participants and delegates from over 70 countries who are interested in cardiovascular pharmacotherapy. And that continues to be our pitch at the ICP to cater to education in cardiovascular pharmacotherapy across the world. And do save those dates. ICP 2022 will happen in October next year in Bucharest, Romania. So I look forward to seeing everyone again next year in Bucharest. Thank you very much, and thank you for your time. Goodbye.
Thank you very much. Congratulations.
Thank you. Thank you everyone for their contributions this round. And again, I'd like to thank all the board members and the governors and the moderators for this session. So thank you, and goodbye everyone. Doreen, you want to lead some heart shape? I don't know, what do you say?
Oh, one, two, handshake, take picture.
Okay.
Come, let's all do.
handshake, take picture.
Okay, ready? 1, 2, 3. Who's taking the picture?
Okay.
It's you taking the picture. 1, 2, 3.
Bye. Thank you very much. See you next year.
Okay.
Thank you. Good
Thank
night.
you. Thank you very much.